Good afternoon, everyone. It is an absolute pleasure to be here today. Carolyn, thank you so much for asking me to present on this topic. When Caroline asked me to present on this topic, I thought about, I don't know why she's asking me to do this, but I'm really glad that she did. And I'll tell you why. When I started to write this presentation out, it hit me really like a ton of bricks while I was going through. My God, as a healthcare provider and somebody running a healthcare practice, there are some fundamental things that during this process of the Inu grantee that my team and I have forgotten. And my manager of nutrition services and the project coordinator for my grant, Heather Engelman. Heather is here at this presentation and she's smiling because when we talked about this, we was like, oh my God, how did we ever forget this? So as we're going through this presentation, hopefully it will be helpful. I'm happy to answer questions, but know that these are things that are coming from our side where we've actually put this into practice. We do this. We're definitely not masters of this, but hopefully, you can glean something from this and it will help you as part of your referral process. So here is the agenda. So we're going to go through building your referral network, who to ask for referral, when to approach, how to approach. The second part of it, deploying your referral network, rules and boundaries for getting and receiving the engagement. And the second one is the engagement. So let's start with who to ask. So referral work, as we all know, based on relationships, right? People don't just send friends, clients, relatives, anybody to just strangers. I don't know on this presentation how many of you, what your role is. Let me just say, let's assume that some of you are social workers, some are dietitians, some are care managers. Odds are when you introduce yourself like I'm a social worker, I'm a dietitian to whoever, people don't really understand exactly what do you do and what exactly do you want. So let's see how we can change that, how you introduce yourself. So for example, you say, we help people set up for meals and housing, right? Instead of saying, I work at the area agency for aging, or I work in the senior nutrition program. It really doesn't say much what you do when you introduce yourself as that. Ask your clients, how do they perceive you? What exactly do they think and how do they think that you've helped them? Use that language to get to other clients. Now, all of us are here on this call right now on a webinar. Now, there are things that we all could be referral sources for each other by sharing our contact information. Now, in this world of technology and during COVID, a lot of these cards, business cards that have come up, which are electronic. So I should be sharing my information here. You'll have mine, but I don't have yours other than seeing your names on the screen, or if Caroline sends me your names, right? And you won't have mine. So there are electronic way, while on a Zoom call, you can have these electronic cards are called Mobilo, Hi, Hello, Bling, Popple, and these can be during any one of your calls that you can do that. Now, when you are getting a referral from somebody you provided service, those are just the one-off referrals. They are helpful, but your main goal is to build a steady stream of referrals. So you must methodically focus on people who regularly deal with the people who will send you clients. Who could that be? The hospitals, your safety net clinics, primary care physicians' offices, ACOs, elder care attorneys, accountants, insurance agents, right? And what happens is we're a primary care practice, a huge primary care practice in Rockville and in Washington, D.C. But I can tell you, in all my years of practice, not a single person ever came from an area agency on aging to our office to tell us about the services. The only service that we knew about that they provided in the elder services was adult protective services, right? Primary care physicians are where we need to know all of the things that you do. So obviously there's that gap in there that needs to be connected. And how do those referrals come to you? Develop a list in Excel, who you know, how you met the contact, etc. That would be the best way to start. You don't need an electronic list. You don't need to do any of that. You just need to have an Excel spreadsheet, and most of you are probably doing that. When do you approach? Do you have a storyline for what are you trying to tell people about? What do you do? What is the service that you provide? Do you have a network of supporters? Do you have written materials to provide them other than just your business card? Do you have something at the back of your business card? And if you're trying to get them to do referrals, do you have data? So just think about, let's go back to that Excel spreadsheet. You have that Excel spreadsheet. Look at the sheet and see who are your best connections that would be. Who are your maybes? You may not get anything, but you put it in another list. Once you've gone through all of your social network, leave a blank space to list the referrals that they send you, if they've sent you any referral, right? If your list is short, that's okay. Your goal now is to get a network up and running, so focus on your most likely prospects. So for example, for our Inu grant, we were focusing on healthcare. Our most likely prospect, we thought, in our state was our innovative program that the state had called Maryland Primary Care, right? That's what we focused on. But was that the best thing that we could have done? I'm not sure. I'm not sure that that was the best, because what happened was we went to just one contact where we thought we could get everybody tied to that, but that's not how it worked. Every individual practice in that Maryland primary care needed to see us face to face, and we needed to have a relationship. They needed to have name recognition for them to send us patients, the referrals, regardless of how great our program was, whatever we had done. That relationship with the individual practices did not exist at that point. So remember, everybody hears of the golden Rolodex, right? If somebody walks away from a business or takes it away, they say, oh, all the contacts are gone. Those contacts are very essential. They're not just company contacts. It's not just one person who's responsible for that contact. It's everybody in that organization is responsible to build those contacts and share the contacts with the rest of the individuals in your organization. So how do you approach these people? Not everybody wants to. It's like, it's one of those things, no one likes to put their hand out and say, oh, could you give me a referral? Could you send me a referral, right? Nope, you're not comfortable in that. But remember a few things. You won't be talking to total strangers. Think about back to that Excel spreadsheet. You're not talking to total strangers. You've honed down your list. You know these people. Just as you need them today, they'll need you tomorrow to help them with their clients that they have or for their referral. Most importantly, you're building a relationship. You're not trolling these clients. The relationship is what helps you and your referral source trust each other. With these thoughts in mind, use the relationship you already have as the foundation of your referral relationship. If you occasionally say go out to lunch with a person you want to ask for referrals, ask them to lunch and talk about referrals. If you go running with them, or you go to the gym with them, or do some other activity, speak to them about your program. For people you don't know personally, you'll want to take the time to get to know them, so you know which ones are good fits for referral relationships. So let me give you an example that happened just recently. Over time in our community, we've developed many relationships that there are times I can pick up the phone if I need something we're applying for a grant, we need a letter, right? They know about our program. We've built a relationship. We've helped their clients, and it's there's reciprocity there. They will be very eager to be part of the next program. However, and that's exactly what happened. But there was one individual that we reached out to who we had just met, and we asked this individual to give us a letter for a grant. And guess what? That letter never came through. He didn't know us. We just had a little chit chat at a luncheon somewhere at the chamber, but didn't know of our work, didn't know how we operate. So there was no history there, and we didn't get that. So those relationships, as you nurture them, as you get to know the individuals, where they work and how they work, and they know what your work is, you will make sure that they are always in your corner. So I have, what is the hook? What are you trying to get them to do? And what is your line? What is your elevator speech to them? And how do you reel them in to get interested in your program? So for example, for our Innovations in Nutrition program, which is our diabetes program, we know that in our state of Maryland, diabetes is a state initiative that they really want to improve type 2 diabetes, individuals with type 2 diabetes and their outcome. Physicians, primary care practices, endocrinologists, hospitals in the state of Maryland, that is one of their main goals, how their payments is structured, that they will get additional money if the outcomes for those individuals with type 2 diabetes improves. That's the one thing that we kind of use to get them interested. That's just to get them interested. That doesn't necessarily mean they're going to send us all the referrals, but at least there is a start for there to be a common ground where you can get them to understand and know that, okay, we need to give some time. Let's talk to them about that. Explain that you sometimes have clients that are looking for referrals and you're expanding your referral network so you can make recommendation. It goes either way, whether it is for healthcare and whether it is for you. We in healthcare need social service organizations because we don't do that, right? We need you to be able to provide those. But what happens with that is we forget that there are some things that are different in healthcare and in social service organizations, which is what? The common goal all of us have is that we want to improve the life of the individual or the outcomes that we are serving, right? But what we try to do is we don't explain what we are doing that well. So for example, let me be specific and talk like a normal person. If I am going to say to Caroline, I want to help your older clients. We can help them and by providing services at home, and this will avoid unnecessary nursing home admissions and long-term care and hospital readmissions. Right there with Caroline is as a person who works in healthcare, and she is getting dinged by Medicare for readmissions. She's going to make sure that she wants to listen to me and to make sure that is there a benefit for her patients or the individuals she serves to partner and send referrals. Now, all of the things every time cannot be just about us trying to get referrals. It could be that we can just be connectors at certain point. We can connect to different organizations, just as Caroline can connect Denise and Heather together because they may be working on something similar, but they may be able to benefit from each other and share. And so sometimes it may just be that you are a connector. So let's recap. How to build a strong referral network. Make sure your work is worth sharing. Choose the right types of your network. Motivate and track your referrals when you are sent a referral on that Excel spreadsheet. Show what's in it for them, the people who are sending you the referral. Nurture your best advocates and your best referral sources. And thank your network members for your referrals. It is extremely important. Now, each of us work in our own areas, in our own silos. One of the things to do is to get out in many different areas. For example, you can belong to your Chamber of Commerce. You may have senior networking groups that you can belong to. You can have nonprofit groups, small business area. You can belong to a lot of these healthcare organizations too in your area. Like we have lots of them. And what does that do? People get to know you, people get to know the work that you do, so that when you have a program or a new service that you're delivering, they're right there with you and you can start to talk to them about your referrals. So let's go on to deploying your referral network, the rules and the boundaries. So let's say, what does that mean? So most of you are familiar with that a lot of the aging network services do programs like the CDSME or the DSMP programs. We in healthcare have no idea that those programs exist. So for us to send referrals to those programs, we need to have information about those programs. How do we refer to those programs? Who does those programs? What's the data behind those programs? What's the cost of those programs? Right? We don't know. So one of the things that I know in our area, a lot of programs suffer from those DSMP programs and CDSME. They don't get enough referrals. Well, if people outside your network don't even know those programs exist, you're going to have a hard time getting referrals. If you get a referral, if Heather sends you a referral as the primary care physician, she sends a patient to you and says, here's a referral. I want this individual to be in your DSMP class. What should Heather do? Yes, Heather obviously enrolls the person, does her screen and enrolls the person in the group. But there's a crucial thing that has to happen. And that crucial thing is called the two-way communication. Once you receive the referral, doesn't necessarily mean that your work is done. You need to go back and make sure that you are providing the referral person the information that how many classes that individual attended, what was the outcome of that class, and so on. This is the crucial part that healthcare thrives on. because when a referral is made to anyone, they expect that closed loop. They expect back the information about what did really happen with that individual. Did the services get done? What was the outcome? So during our innovations in nutrition, this grant process, what did we do? What did we as a healthcare entity that we do this all the time miss? We did not provide our partners who were working with us and we didn't close the loop with them. We didn't tell them that this individual had so many MNT sessions. They did the DSMP classes. We didn't. Once we got the thing, we said we picked up the patient. We didn't do anything after that. The other things that are important for healthcare is HIPAA compliance and tracking of the data and being integrated with the electronic health records. As a provider sending referrals to multiple things, they are not going to do if it requires more things for them to do than clicking a box in the electronic health record, right? So healthcare pretty much in this country, whether you agree or not, whether we are disjointed or whatever, we are all connected. Almost all physicians by law are required to use electronic health records if they take Medicare. So pretty much the providers are connected. But where the referral needs to go, if they are not connected with that, or it's not going to happen. This is something that we learned during our process, that our grant is healthcare physicians were saying, what box do I need to check in order to send you the referral? If our answer was to them, well, we're not really connected with your electronic system. And they would say, I don't have time to do anything more. You see, you lose them right there. And I'll come towards the end with how Maryland is connected with technology. I'll do that separately. But that is really the beginning and the end of it. You will lose them right there. So we have to think about how we can connect using technology with them for that process to be seamless. So second thing, you keep your channels open. Like one of the things that we tell the individuals, our healthcare partners, we will contact an individual that they've referred to us 3 times, 3 strikes, and then it's out, and we will let them know. When we get the referral, within 24 hours, we call the person. We don't hear from them. We call them in 48 hours, and then in another 48 hours. If we haven't been able to reach them, we circle back and say, we've been unable to reach the individual. We've done 3 calls. Maybe you need to call them and let them know. Lastly, I would say respect and professionalism. Build trust by mutually setting clear goals and expectation. Work together to monitor those activities and define goals if they are not working. Here's another example. So part of our process is for healthcare to send an individual to us is they have to do the hunger vital signs screening, right? To see whether an individual is food insecure or food secure. And what we were finding was that we weren't getting that information from them, or if we were getting the information from them, when we did the touch point with the referral client, they didn't agree with what was sent. So we we talk with them, we discuss with them, and we decided that even if they do that hunger vital signs screen, that's fine. But at the first touch point, we will do our own hunger vital signs screen and see if that, and then we'll send them the information. They were happy to do it and know that this is a paper thing that they're doing, even though we all are hearing about the social determinants of health. Providers in healthcare are supposed to be doing these screenings, and they are embedded in EHR, in an electronic health record. I'm here to tell you that is not true. They may be in some, but 90% plus, it is not. It's a hand tool. It's a paper tool that is there. It's not done electronically. Not that they are not willing to do the stuff, where the professionalism piece comes from. It's not that they're not willing to, or that we are not willing to do our part. Our roles are different. But as long as we can communicate with each other and we can continue to support each other, that referral becomes a positive, and they also feel good about having sent us that referral, and not that we're making more work for them. So here's the next piece, the engagement. This engagement is really critical. And this engagement is not at one time. It's not at a point that you're doing a grant. It's not at just one point when you're doing a service. This is to be an ongoing thing, an ongoing engagement of individuals, and in different ways it can be done. If you are providing a service and you have current clients, you can give them updates by emails, you can do regular newsletters, you can do a shout out on social media. If you don't have something regular, maybe once a quarter or once in 6 months, you can have a meet and greet with highlights. You can have them as co-presenters at a conference. You can write an article together. So there's always, they always think of you in a positive way and know that in the work that both of you do together, that there are, for them, there is something in it for them. So what are the components of the ideal referral, and how do you deploy? So review the referral timely, somebody sends you, contact and set the appointment, provide feedback, close the loop, gather feedback of the individual, get a testimonial. And this is something that I learned during the conference that Caroline had done back in August. Get the individual testimonials. Those testimonials speak volumes. They will give you more information, and it goes back that your referring partner feels good about too. And share the results. You don't have to wait to share your results until your program is over. Your results you can share monthly, you can share quarterly, somewhere where they can see the results of what is happening with their client that they feel good about. Everything that we do, all referrals, everything that we do in this world, in this age of technology, we need to have a technology platform. And I would not do justice to this presentation if I did not talk about referral platforms. Many conversations that we all have, we discuss, we talk about technology, right? And I decided to pick Colorado when I was looking, because every state has many referral platforms going on. I decided to pick Colorado because it really has quite a number of them that they are working closely together. So if you see on your screen, Activate Care, this is in 42 states. It's a community exchange network, and it offers services, technology, it does data analytics, and it kind of connects healthcare and social services together. It also engages with 211. a lot of government agencies and accountable care organizations and hospitals in that area. Gelato is another one. Here, this one, as I said before, healthcare is very concerned about HIPAA. So you will always get a question. If I'm sending you a referral, is it HIPAA compliant? What platform am I using? That is really key. So this is a HIPAA compliant platform. It's based in Colorado Springs, and it can proactively manage all of the referrals that you send, and the individual's personal health information, the social referrals, and all of them. You have the Quality Health Network. It again does both the healthcare and the social side of it. Aunt Bertha, I think all of you probably on this call are familiar with Aunt Bertha. It is probably one of the oldest platforms that connects the social and the community organizations. Unite Way is another one, and then 211. These are all many different types of referral platforms available in the state of Colorado. Now, let me talk about my state of Maryland, where I am. In Maryland, the entire state healthcare systems, whether you are a hospital, whether you're a primary care physician or any type of physician, whether you are a LabCorp or Quest or a radiology service, everything is connected through what is called the Chesapeake Regional Information System. It's CRISP. All of the referrals, if we need to send, we can send it through CRISP. The downside of CRISP is not integrated in our electronic health records. It's a separate standalone system with its own portal that a provider has to sign into in order to look at results, look at everything, and send referrals. Now, in 2019, CRISP was opened up to do a pilot for community-based organizations. So some of the food banks in the area, some of the other social assistance organizations were in the beta phase of it, and they were integrated. In 2022, with our program, our Innovations in Nutrition program, we started to get the Area Agency on Aging with who we were partnering as part of that integration as a community-based organization. A few of the things that we've learned that because CRISP is not integrated in the electronic health records, and because Area Agency on Aging don't really have a way to get these referrals in a HIPAA compliant way, and they're not really set up, we had to decide that there was only some information that could be shared with them. And one of the things that we also know is that the healthcare needed to get consent in order to send a referral to the Area Agency on Aging through CRISP. Those are all steps, additional steps that we have to do, right? So it's not that easy for a provider who really wants to send a referral, that it's easy for them to send the referral. So we have all these diverse platforms, but until they're integrated in the electronic health record, whether it is in Colorado, in California, in Maryland, it's going to be difficult to get everybody on the same platform and to get those seamless referrals that we all would like. That is the end of my presentation. I hope it was helpful. So here's the nuts and bolts of building a successful referral network is, it relies on communication. Really, it is the key to keeping our networks and our referral sources happy and together. I'm happy to take questions if there are? Thank you.